استنانا يا ياسر، هنبدأ الريكورد.
ماشي.
خلاص recording started already. Can start يا دكتور ياسر.
No, I will introduce him يا إيناس.
Okay.
Okay.
Sorry.
Okay, welcome everyone. This is our sixth lecture in our lecture series, Unity Through Knowledge, hosted by Sudak and the Anesthesia Board in Sudan. Today, we have a dear guest and friend, Dr. Yasser Mohammed Reda Tulba. He is well known to a lot of Sudanese doctors. Dr. Yasser spent some times of his training in Sudan. He's an elite pain and regional physician, well known in the Arab and in the diaspora for many doctors. Without further ado, we welcome Dr. Yasser Mohammed Reda.
Thank you everyone for coming after work, and everyone is tired, so I will try make my presentation as long as possible to cover the subject and as short as possible, not to get sleep or to get poor and full sleep. So I will give you an review about the basic of ultrasound and regional anesthesia, and maybe touching some pain, because the pain is a very big umbrella covering regional anesthesia. So this is my beautiful city. I hope one day to make a conference there to invite you, all of you, to come to this beautiful city. It's called Ras Al Bar, and it's a picture from the Nile and the sea, and it's like a peninsula. And I don't have any conflict of interest related to this topics. So when I ask you what is the pain, this is what's called a confusing definition. For me, I don't understand. From the time I know that unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in the term of such damage. It was the definition like this, but after about 8 years, just try to revise it and to make a new revision, putting or resembling the associated with. So I don't need to understand from this one, except more confusion for me. It is just hard thing, and the pain is very difficult to measure, not like a blood pressure or other measure to dial like a lab. It is a subjective sensation expressed only by the person, and you can tell this bread looks like in pain and sad, and if this barrel on the right side, even with one eye, looks like I'm smiling. So it is just hard. And I think we agree that pain is subjective, pain is underestimated all the time, and pain is undertreated. And the words no pain, no gain is not right for pain management, because if the patient have pain, he will lose everything. And I can tell you that the pain is the use leaving the body. And this is a very big presentation to digest in this time, but I will try to eat as possible as I can. This is a picture from Iraq, the country of hospitality. What is interesting in this picture? Anyone know? Ines? I
Big
can't Diet Pepsi, at the end, Diet Pepsi. Yeah. So my objective to this presentation, I will give you a brief introduction, speak a little about physics for ultrasound, anatomy and sonoanatomy, tips and tricks, example and rule, and at the end, the conclusion. We know that ultrasound make our life easy. Because it is a portable and dynamic machine, very small machine, less expensive, no radiation, non-invasive, no hazards, high resolution. You can see the picture, and with advanced technology, available technology, fast diagnosis, and the diagnostic block. From the data, from the what's called the evidence, we know that now the ultrasound regional anesthesia chrome pain improve the outcome, efficacy, profit, and satisfaction. And he give you a very good chance to see what's inside the earth without digging, and what's behind the door without opening. And this is the only machine which give you a video, MRI, CT, and other machine don't give you any video. And even if you give a video, give a big amount of radiation, so you can make a dynamic examination. It is like a professional photographer manipulates his probe, his camera by pulse technique, positional alignment, rotation, tilting, sliding to get the best pictures. And we are inspired from the nature, from the military innovation about, the bats, so he can't see, but he fly very fast, sending an ultrasound wave and responding. And according to that, he can just find his way. What is ultrasound or ultrasound wave? Human audible range from 20 to 20,000 hertz. We can hear this only. Below it, above it, you can't hear it. But diagnostic ultrasound is from 1 to 50 megahertz. It's a very high frequency. Really, we don't see it, but we can hear it. And if I ask you, can you see by sound? You tell me that yes, because I'm over here. I'm a superhero that I can see by ultrasound. And this is a process coming from vibration of some crystals, giving what's called sound. You don't hear it, and this sound affecting by a tissue and reflected again to the probe and displayed on the machine. So the probe is the heart of the machine. The most important layer here is the single crystal layer. When subjected to electricity, it changes to make a vibration and give a sound. And when the sound come to it as a physical thing, make a vibration for the crystal, make electricity again to be displayed in the machine. So the machine, the ultrasound probe, which heart of the machine, is like a speaker. He send and he receive at the same time to display the picture. It is not like anatomy, but it's like a negative picture of anatomy. So, and the image quality, it depends on the what's called acoustic impedance of the tissue. So the fibrous tissue have acoustic higher acoustic impedance than the muscle. So it give you like a white streaks here. And at the end, the computer processing make like a megapixel for the camera, showing the picture. So we know that the transducers, they have many transducers. But for us, the most important transducer is a curved one, which have low frequency, usually from 3 to 5 megahertz. And we have a higher ultrasound, or it's called a higher frequency, which is linear one, and usually going to even to 25 megahertz now. And you know that the small words about the transducer, which time I use this one and the other one. The curved one, he can go very deep and up till to 35 centimeter. But at the same time, he don't give you a very good picture. It's called a bad resolution. But high frequency, because high frequency absorb it fast, but it can give you a very superficial, a very good picture. It's called high resolution. So we have these two only using in pain and regional anesthesia. We have many other probes used for other specialty. So using curved array and linear array. Linear array, as I told you, is for superficial structure. Can see a very good picture, but it can go deeper. But with some technology now, it can go deeper. It's called special tissue imaging or harmonic wave. And the curved one, you know that it can go very deep, but it's going to give you a very good picture as you want. So the attenuation, which happen by tissue, when I send a wave, you know that the high frequency attenuated first, so it can't go deeper. But low frequency can go deeper, and the attenuation is very less. But you know that every day you found a new thing, because there is a small tissue harmonic imaging. They give an ultrasound wave, and second wave is double this wave. It can give you a very deep pictures and a very good resolution, and also can adjust the image itself, the sector for the image. Also, we have another technology called special tissue imaging. He give you a wave different direction, so can give you more picture to see the good picture and see the needle in better way. And also there is a linear probe with different sectors. This one probe you can use for everything. You can adjust himself by artificial intelligence. So in simple words, when you go for deep, you go for curved one. And when you go for superficial structure, you go for linear one. But you know that from my experience, and this is written also, in some area having this exception, that this area, the first area is suprascapular nerve. Second thing, the back. Third thing, subgluteal sciatic. Fourth thing is the sacroiliac joint. And all these areas, the curved one is more bitter, even it is a shallower, but it give you a big sector. You know, the technology now can give you a big sector or the linear one. So I think it is not more difficult than these people doing, but with training, you know, you become a professional. Even Mr. Ben, with some training, he become so professional. Sorry, this is Photoshop. So with some what's called phantom training, like water bath phantom, gel phantom, even chicken or meat. Again, when you started your career, you found all the pictures the same. I tell you, this is an artery, this is a vein, this is a muscle. But for you, when you started, it's normal to see all the same, no difference. And in every step you go, you have a problem. So you must prepare yourself for that. And all the time, you must have a second plan. Because I make a block, but I must put even 1-2%, the block will fail, because in the best hand, the block success is 95%. This is from a study from America. So, and this is my picture when I attended this presentation. And if you feel like this and you don't understand anything, it's normal. So there is some roles for ultrasound, and this is a very important thing. When I tell you that the nerve above the clavicle is black because you don't have enough fibrous tissue, when this nerve gone away, this nerve gets some tissue and become like honeycomb. So according to this, where nerve above the clavicle is black and the artery is black and the vein is black. So don't mix a black bubble in the neck, because injecting in the artery can get immediate convulsion or arrest. So the local anesthesia going to the brain in very high concentration. And again, when you go for any area, especially for the neck, you must use a color Doppler, because as I told you that the vein, like a nerve, like artery, so an easy way to put injection in the nerve. And don't inject under pressure, because under pressure, maybe you are inside the nerve, you can rupture the nerve. So if you found a pressure, don't inject it. And you have a case report about that. Someone of the anesthesia technician injected in the nerve, and popliteal, and the patient get immediate full drops. And the patient recover after 6 months. And they're abusing me in my clinic. All the time when you go for block, which block I use? As a general rules, you can choose what's called the most distal block can fit the procedure. For example, if you make an hand surgery, axillary block can be, and so infraclav can be, supraclav can be, but usually as a rule, to use the most distal block for fitting for this procedure, except if you need, for example, some analgesia for to rid the cabin of the tourniquet. And also, which block I chose, this is for anesthesia, for analgesia, the nerve block, or facial brain block, or perivascular block. Also, you must use the least volume to float the area. You know, when you started our career, you injected more and more and more local anesthesia to get a toxicity for the patient, because you are scared for your block to fail. And this is a wrong practice. You know, you must inject what's called and list volume and less concentration can fit for this procedure. You must consider anatomical variation. I will tell you something about anatomical variation. You know, the Gray's Anatomy, which is Bible of Anatomy, is done from written after dissecting only 12 body. You can imagine 12 body, and become a Bible of anatomy. And you know that after innovation of ultrasound, I'm looking and found many variation. And now there is a lot of study running about variation. I can tell you that lateral cutaneous nerve of the side, the variation is 42%. Supraclavicular brachial plexus block, the variation is about 32%. So 1 every 3 have a normal variation. So now the anatomy is not a fixed sign like you considered before, coming from this area, going from this area. And all people working in regional anesthesia looking and seeing this variation. Again, a very what's called small words about mixing local anesthesia. When you started your career, you found all people mixing local anesthesia to get the two benefits, the best of the two benefits, to get a fast acting and long duration. And this never happened, because one of the determinant of this what's called fast action is pKa, but also the concentration. Because of that, a drug like chlorobrocaine, the pKa, like an levobuprofen, but working very fast. Why? Because the concentration is 3%. This means 30 part per ml. For other one, levobuprofen is 0.5 part per ml. So mixing local anesthesia to get a fast action and long duration is not happening. The duration become less, and don't get any fasting of the action because diluted the local anesthesia. Because of that, you must thinking seriously about additive to local anesthesia. There is some drug more safer can be added to local anesthesia, can improve the quality, decreasing the dose, give you more time, and can sometimes give you some sedation for that. And remember that when you put a needle to the nerve, don't touch the nerve. Because when we learn from nerve stimulator, when you are about 0.5 centimeter from the nerve and you inject and it works, don't touch the nerve because you can injure the nerve easily. And the most important thing when you inject around the nerve, you know, some book write that's like an 15 mil, and the other book write 25 mil and 28 mil. The most important thing about that, you see the area flooded. I see the witness distribution. You know, sometimes I make an interscalene block by 6 mil. I found all the area flooded, so I don't inject anymore. And sometimes Still not flooded, I inject more and more. So you must thinking seriously about concentration, dose, and volume for toxicity, and thinking also the time of operation. When I get, for example, exploration of the hand, it takes 6 hours, 8 hours. I look long-acting local anesthesia, good on higher concentration. When this operation, the patient will go home like a fistula. You must use what's called short-acting and nothing to make a numbing outside, and the patient get a problem for his arm. And so, what is the factor affecting the dose and concentration of local anesthesia? You can tell the body weight is very important. The operation, associated disease like diabetes, you don't need a very high dose. Also, the male or female, usually male take more, even the toxicity in female more. Again, this patient is a daycare or hospitalized because I can't discharge a patient with numb hand and get a problem for legal issue. Also, the associated disease, the patient have arrhythmia, it is unwise not to give him an arrhythmogenic local anesthesia. So again, all the time you want just to go by your own needle and you don't see anything, you must aspirate for blood. You know, the other day I was making an electrospiny, which is an what's called a bloodless area. So every time I just go and make a suction, I bring a blood. So, but don't remember that not every needle in the vein or artery bring a blood. About 25% of this vein or artery don't bring a blood because it's sealed around the tip. So the most important thing to know that you are intravascular when you injected your fluid and you don't see the fluid. This is the most important thing. Also, which probably I can use, as I told you, the superficial and deep and some exception, and to put your target in the middle of the screen, and don't put it very shallow or be very deep. Usually, you put in the middle of the screen about 1 to 2 centimeter deep only. And don't forget the orienting structure. What is the orienting structure? By definition, it is a structure I can't miss by my eyes, like artery, pulsating, dancing, bone, shelf. Also, some character of the muscle like an sartorius or flexor carpi ulnaris, like butcher muscle. I look for this structure, and after that, I search for my my structure I want to block. And sometimes it's not as you see in the anatomy. Again, before to go the block, all people excited to make a block fast. And for me, and I think Muhammad Hussein, I remember was working with each other on make another side, and someone just make another side for the surgeon because the surgeon take a 30,000 real, and the patient stop breathing because don't make a bilateral block in the neck. You can block many things. So don't go fast. It must stand and to see everything and to follow a guideline to see the marking, to discuss the case with your colleague, to discuss this is a true patient. Most of us, I think, make another side, and it is a what's called unacceptable thing. So this is like aviation, like a pilot. You must make a checklist for everything before to go to avoid some of this complication. And to make a time out to verify patient ID, surgical consent, side marker near the surgical site, patient questioning to asking him, it may be another patient. Both prior to block, which is the patient and the team. You must stop before block to start it again. And don't forget monitoring, because this is block like an operation. Don't make it in a way. You must make it in block room or equivalent like a recovery, like an operating room. So and also to monitor the maximum recommended dose, low dose to achieve the desirable result, as I told you. And all local anesthesia, remember, as vasodilator except cocaine, the vasoconstrictor, locally. And you know that sometimes when you become a professional, you get an ego, and at that time you get a many complication, and not just going for the junior one. It may come for the senior one, and no one away from complication. And this is not a problem. But if you get the complication and you discover it and you treat it early, this is what we need, because no one can stop complication. Also, when you go for block, usually use a frequent aspiration, because you can inject intravascular, which you can what's called toxicity by a very low volume. And when you injected 2 ml and suction, 2 ml, 3 ml and suction, and you communicate with the procedure man. And you must inject first, especially in a very crowded area like a neck, to inject friendly fluids, glucose 5% or saline first, because sometimes you injected in the wrong place, and this dose is counted for the patient. So you need to inject by friendly fluids, and after that, when you are sure about your needle, you can inject your dose. Some people just speak about tracer epinephrine. I don't never use it about 10 years back, and there is many complication about it. If you inject inside the nerve, you kill the nerve. Our case is, alhamdulillah, was not adrenaline. The patient recover after 6 months, but with adrenaline, what's called ischemic injury, the patient will not recover. So and also, not just you need to have the drug for local anesthesia. You need to have a place or drug for resuscitation, especially interlipid. And you must know some data about the local anesthesia use. You don't need to know about everything, but you need at least, if you have a different category, you need to know the speed of onset, duration, toxicity for everyone. And also, the maximum dose was lidocaine with epinephrine, which is, some people use it, 7 milligram per kg. Without epinephrine, 3 milligram per kg. But I tell you, a little people speaking about not to use this one because of our safer additive, and it used only during the time there is no long-acting what's called regional anesthesia. Bupivacaine with or without epinephrine, 2 milligram per kg. Some people say 3 milligram, and usually I think it's not working because not a mechanism vasodilatation to make a vasoconstriction. And remember, when you injected a patient, and anything will happen for this patient, thinking seriously about local and systemic toxicity. Because if you give the patient interlipid and you don't have a toxicity, you don't have a problem. But if you don't give it and the patient have a toxicity, he can die. And remember that systemic toxicity have type 1, which is very famous to kill the patient, and type 2 when you have some reaction in the patient, but not as severe like the first one. And remember that there is a local anesthesia systemic toxicity, not just an generalized toxicity. And this toxicity happens when you inject in a very high concentration in the muscle, for example. And this is the only time when you get a problem, when the surgeon sit down like this and he don't speak and don't rush you, and he said keep calm and blame anesthesia. So fat is a very good thing to use, not all the time bad. And this is a medication just to rate the toxicity happen. And there is a local assessment to see checklist like an nomogram, how to treat, or how can you check how much you give and how much to give it more. But unfortunately, this is not supported by good evidence. It's just someone suggested and all people follow it and no one just revise it. When I drink alcohol, this gentleman said, everyone say I am alcoholic. But when I drink Fanta, no one say I'm fantastic. This man make a comment because you are looks like Coca-Cola, my dear. So about the anatomy, as I told you, remember that all the structures not have a static place. Anatomy is a dynamic science. So brachial plexus have a variation about 32%, and there is many variation. Variation lateral cutaneous, I tell you, about 42%. Musculocutaneous and sciatic anatomy. So musculocutaneous, someone just called me a few months back because they make an axillary and want to make a musculocutaneous, but they don't find the nerve. So I search everywhere, even any fascia can be resembling the nerve. I don't find anything. So other side, I found a very big star-like musculocutaneous nerve. So Ramstead, he said that because the face is not the same, anatomy is not the same. Not even between people, even between right and left side from the same person. And this is a get share from Queen of England because he was a great man for the anatomy. So anatomy have a many variation, and to know that the sciatic nerve, just divided in the popliteal area. But to know for your knowledge, the sciatic nerve is not one nerve. It is coming as posterior tibial and common peroneal coming as two nerves from the beginning in the same fascia. And in 8% of the people, this nerve coming down alone for everyone. So remember also nerve overlap. Sometimes this area supplied by linguinal lymphogastric, but don't ignore that area merely supplied by genitofemoral. This is what happened to me. I have a patient post-surgical and I have a severe pain in the area of linguinal hypogastric. So I make injections, the patient don't get any relief. When I try to make genitofemoral, it works in a very good way. And remember that we don't have osteotome map. We don't have myotome map. That we have and sure about is called dermatome map, as you see in pictures. And to know that, for example, the sural nerve usually coming from common peroneal, and sometimes coming from tibial, and sometimes come from the nerve. There's many variations. And ultrasound, not like a real anatomy, like a negative picture, if you remember this picture. So if you see this lady in a real way, this anatomy. And if you see in a negative one, is what's called sonoanatomy. But remember, you will not know this lady if you don't know her as anatomy, because you need to know anatomy and study anatomy, even with this variation. And this picture also for me, this anatomy 10 years back, and this sonoanatomy. And also how to see the structure when you go by ultrasound. You know that in every structure, you're looking for the tissue like a muscle and bone, as I show for you here, and also the nerve. Everyone have a character. So putting the probe in what's called accepted way, you can show a very good picture for the sonoanatomy, but it needs an education. If you're looking for this one, if you look, for example, for being blocked, I see the structure like this in anatomy, and in sonoanatomy, I see the structure like, this sonoanatomy. So it needs a long journey of training. And this is when you put a probe in a different area for interscalene, supraclav, infraclav, and axillary. In every area, you found some arrangement for the structure. And this is how to see by ultrasound. Also, don't ignore the artifact. Sometimes you see artifact. What's the artifact? This artifact, by definition, is something not exist. And sometimes it is something exists, not exist. This picture have a very funny story, the real story. This man from Vietnam and get an X-ray, he get a cough, and he went to get an X-ray, found this insect inside his lung. He went to Japan and to see what's the problem. And in Japan, they make an X-ray, don't find anything. At the end, they found this inside the machine. So this is what you see. Sometimes you see this artifact, not found it. I will see by another way. This lady holding a tissue like this. If you look for here ultrasound on the wall, you see it's pregnant. This man can't be sitting down during flying off this plane. And that you must thinking for other things like an artifact. Or sometimes you don't find the image at all. You need adjustment to see it. What happened in ultrasound, you can see the edge of the artery is like a black streak, because this is the ultrasound to go to the wall of it. Also in this picture, see after the artery here is called the post-acoustic enhancement. This is not a nerve. This enhancement because the difference of ultrasound wave, which is 1540 in speed, different from tissue to fluid and fat. Also, another picture down is called post-acoustic enhancement, shadowing. This shadowing because there is a calcification of the arterial wall, so you don't see anything like a bone here. And this is some sort of artifact. Also, sometimes you go by the needle, you see many needles like this called refibrance. And it is only one needle, but this is some sort of artifact because the waves are sliding from the wall of the needle. Again, another thing, if you look for here, you found this was called subclavian, but inside the lung, I found another subclavian. I know that there is no subclavian in the lung. It's called mirror image artifact. And if you're moving the probe a little, everything will come back in a better ways. Not need just to adjust the your probe and your needle. Another thing you see here in popliteal static, the needle is bended, and it's called bayonet artifact because a different wave, different speed of wave in different structure. Also, usually all the time you're adjusting your machine to see the best picture. You remember the man which you get in pictures, and you need to be like this, professional photographer, and you need to play with your what's called unfocus and to adjust again to see the best picture. And best picture is different from one to one. There is some terminology usually said in ultrasound, hyperechogenic and hypoechogenic. I don't care what anoic and isoic. So hyperechoic when he become more white, hypoechoic when become more black to the tissue. And this is how to describe. This is a white and this black, and you see hyperechogenic and hypoechogenic. Again, gain adjustment is very important. As you picture, the gain high, the gain is good, and the gain is less because it become black. This is different from one to one. Again, a very important thing, when you go for a target, you put it in the middle of the screen. Don't go for very shallow, because if you inject, you will not see the bottom of this structure. And don't inject too deep, because the sector become very small and structure become very small, difficult for you. And usually make a right adjustment is most right one. Usually this right adjustment 1 to 30 meters below the structure. And this is how to see the reflection of echo from the tendon. Because of that, the Mikan Hamad was called anesthesia skill promotion. You know how to deal with the machine, what's the capability of the machine, how can you sterile the machine, how can you search for the machine. And even This is done for senior people like this lady, beautiful lady. This is a senior one, but just came because not everyone can use a machine in a better way. And that is our anesthesia technician, Hamad. And just we don't teach him about regional anesthesia. We teach him about the machine, how we use it optimally. This machine. When you buy a new car, very advanced car, you can't drive it. I have a car like this. I bring a car from Dubai, and I don't know how can I start it. There's no button to start, and the car resisting me. I try to put it beside the wall and not moving because alone. So you need just to know the capability of your machine. Again, we have many modes for ultrasound. A mode not to use now. B mode was called brightness mode because you give brightness, or 2D mode. It is 2D, not just to give you a 3D, but you must imagine in your brain this is 3D because the structure is 3D. And M mode was called motion mode. When you move, anything you move to want to measure. There is 3D mode and 4D mode. What's the difference between 3D and 4D? Anyone know? 3D when you don't have a real time. It is just as a machine take a picture and make an like processing to make it. So delayed usually. But 4D modes, it is a real time picture. And why 3D and 4D, why not famous? Because the probe is very big, and all people just like to use a simple thing. And there is a combined machine and new modes. Combined machines, there is now an MRI, small one, with a ultrasound, because MRI is the best one for what's called injection, and also the ultrasound give a movement structure. Also, there is a CT with MRI with ultrasound, and there is also endoscopy with ultrasound. The screen divided to make a more accurate, more precision for the structure you need. And also there is a color Doppler or Doppler. There is a color Doppler and power Doppler. The difference between color Doppler and power Doppler is the color Doppler, he give you a different color according to the direction of the blood, and he give you the velocity. He can give you the velocity, but the problem is not sensitive like power Doppler. And he give this place direction of the blood. If you're coming towards you, it is red. If you're going away from you, it is blue. It's not like an arterial vein. And remember that power Doppler is very sensitive, but usually have an orange color, and he don't give you direction if you need it for a small region. When you go for block, for example, this is a 7 nerve root, and this is vertebral artery. Artery like a nerve. So all the time, don't to go with block without to go for color Doppler. This is a very interesting picture for me. This is you have a facet pain, and I was going somewhere in some area, and you have a severe pain, and they have second day workshop and third day workshop. So I can't sleep, I can't move in the bed. So I went for one of my friend. He's not a pain man to do it, but he's a regional anesthesia. I tell him I will guide you, and you can see this picture. He will try to hit this L4 transverse process, but you see the needle slip down here. We can see spinal anesthesia. I tell him to return back to hit the transverse process, and they injected the medication, and this is what's called some sort of lumbar erector spine. So if you're thinking about the block types, 3 types. The nerve block, if you have a very good nerve, and again, if you have a big nerve, it's called nerve block, and sometimes it's called prevascular block, like to it. But that there is a controversy, because some people consider all the nerve block as a fascial plane block, because the fascial plane is by definition is a fascia between 2 muscles. And if you look for interscalene, for example, it's a fascia between 2 muscles. And this is one of the first prototype ultrasound. And if it's still here, without this technology, I think it will not come here to speak about ultrasound. And ultrasound going very fast. This is a first machine I work with. And now we have an navigator, one of the good machine. And there is more better than machine. This machine was called artificial intelligence. Advancing machine, and sometimes using the mobile phone, wireless machine, one probe was dual probe, and this is one called the color ranked ultrasound. This is what's called the color ranked ultrasound. They usually give you a structure like a color to make your life easy. And have artificial intelligence. You can see the color. And usually, don't make a mistake. I was in Denver, Colorado, in March, and I found a machine. It was a Mendeley machine. And Mendeley just, I bring a very heavy person. Sorry. I bring a very heavy person and try to make the to see the different area. For me, I don't see anything because it was a very difficult person, but the machine guide me. And there is a more achievement about the machine. When the machine tell me, or I ask here, I'm doing a right block to go on right side or left side. What the machine tell me? No, just you must adjust your needle and give you like a dot line just to go to make the block by it. You see how the technologies go. I don't know the sun. I have a problem in the slides. Stop again.
It's frozen.
So just I will try.
Frozen. Frozen. فما عارفة how you will fix.
Close the program. I think I close the program. I don't know. Frozen. It's okay. He tell me screen stop. Okay. Just I make it again 1 second.
Dr. Yasser, can you unmute your phone? I cannot hear you.
Now can you see the pictures, the video, the slide? Sorry. You can see the slide now?
Yes, we can see and we can hear you also.
Thank you. I'm about to finish. So ultrasound again used now. I just found a survey 2 years back. About 89% of the doctors, different specialty, using an ultrasound for something. And I found in my hospital, some people have an, probe in his bucket and used for everything. And soon it will replace the cystoscope. And now you know that ultrasound can use in every way, everything, like an airway, like an even to predict in ICU and everything. So now, what about the future of ultrasound? Wireless probe become valid now. Color ranked ultrasound, you have to color, combine the image, harmonic technology, specialty imaging, and artificial intelligence. Even I ask the machine, I'm doing right or wrong, just guide me. But all the time, don't trust the machine. 3D and 4D ultrasound, linear probe with sector, one probe fit all, waiting for more technology. You don't know what's coming. And when you use it in local anesthesia, ask yourself how fast it works, how long duration, what's the profile of toxicity, and when you need it fast, you must use a fast local anesthesia. When you need it long for anything, you need the duration is very important. And don't forget that we are working in an era, you must be at access for everything. So if you make an regional anesthesia all the time, you can get what's called traumatic injury, even related or surgical related toxic injury when you inject inside the nerve, ischemic injury, and this is the worst thing to go. Vascular puncture, it can happen and can lead to hematoma and can lead to what's called devastating complication. And all the time when you're looking, I need more evidence about pain, regional anesthesia. Unfortunately, we don't have the time and we don't have the good constructed study to show our evidence. So according to our recent study, marriage is the main reason behind divorce. But remember that absence of evidence is not evidence of absence. You need a time, you need a good constructed study, because most of our study coming from animal, and this is not reflected to human. This is like a randomization. When I ask you about do parachute save life or not, you can't answer me except when you make a good study to send them 100 people without parachute and 100 people with parachute, and at the end you give me a conclusion. So in regional anesthesia, there is what's called a list evidence like opinion expertise. And before to go, I just remind me about liposomal bupivacaine, even bupivacaine was a non-steroidal, which can stay for 7 days, and also liposomal bupivacaine was approved for many areas, which can 5 days, but not working immediately. He need about 12 to 16 hours to work, so you must use long-acting local anesthesia before it, and don't use an lidocaine because there is a gap for it. I know that the time is confusing and all the condition against us today for the internet and all stuff, and dear God, when this presentation will finish, it will finish now, but this is what's called my sweet conclusion. Safety is paramount. Safety checklist with any nerve block. This is not like an operation. Know the sensory distribution of every nerve and the variation for that, and overlap. Locate the nerve, orient the structure, looking for the structure preference. Gather your equipment, anesthetic drug, which for resuscitation and for the block. Anatomy and variation of anatomy, must know a little about it. So know anatomy, indication and contraindication, valuable knowledge about physics and neurology and for injected drugs, training and experience to minimize the complication, to improve your outcome. And don't forget the role of Doppler orienting structure and complete sitting and safe place, look room or equivalent. Scout, look for the area before to do anything, and to be ready all the time for complication, to discover and to treat. And remember that no one can help you until you help yourself. And the best way to predict the future is to create it by yourself. And this is my reference. Thank you very much for attending this presentation and for any question. Sorry, I was trying to put the flag of Sudan, but unfortunately, come by mistake another country. I'm not again with this country. Thank you very much for attending. For any question.
Thank you very much, Dr. Yasser. It was short and sweet and very informative, as usual. Anyone has any question, you can raise your hands or you can type your question in the chat box. If you have any question for Dr. Yasser about the ultrasound. No questions?
No question. Will people sleeping? I think there is something in the chat, Dr.
There is a comment here, Dr. Yasser. Anyway, yes. If they don't, if there is no question till now, it's from Amal. She said to you, this is a very valuable and useful lecture, because she is a regional fellow. So she's thanking you. She said to you, thank you very much.
Yeah, thank you, Amal. I hope to see you soon making a presentation for your work. You know that I'm Sudani Halabi. I live in Sudan for 1 year, so I know everything. And I hope Sudan to return back as usual. Khartoum was the safest city in Africa when I was there. And I hope everything returned back and, to visit Khartoum again.
Inshallah, soon, Dr. Yasser.
I was lucky to visit Khartoum 2 months before this event, to attend as an examiner and make a workshop with Muhammad Hussein. I think Muhammad Hussein is here. To workshop for regional, to workshop for pain, inshallah.
So we have some question. They're asking you, what is your own experience regarding erector spinae plane block in chronic pain management?
You know that, first thing, if you go for the internet, but this is not updated. You know, on the internet, just write in YouTube, Yasser, Reda regional anesthesia. I found a very interesting electrospiny blim block because I get the data from Marasi Furiros, my friend from Colombia, working in Canada. And they're asking me to make the same presentation, but was updated in Abu Dhabi, this Abu Dhabi International Conference last week. So I have this presentation. So if you're looking for, you know, not just my experience, this is some study. Electrospiny in facet pain, very effective. In musculospasm, very effective. Myofascial pain, instead to inject 10 injection, you injected one here and one here. In some neck pain, if you go for T2 and T3, injecting 18 ml, it can make a very good result. For also if the patient have an blatant screw fixation and can't make an epidural, usually this patient have a facet and have strain on the back, and it's working very good. So it can work for everything. It can work for anal pain, for proctalgia, also for I have a case of fracture sacrum. Is all the healing fracture. I have a vein. It's working with it. Usually it works also because it's not an erectospiny, not only a thoracic as you said at the mean. It is a cervical can work in cervical cervical fixation can work on thoracic, which is a main one. A lumbar now we're using in many things in lumbar, like an called chronic pain for non-specific chronic pain, facet pain, bleed and through fixation. You can make an epidural. It can work on this all these people. And usually in chronic pain, it works for many months. Usually the mean relief it will be around 6 months. Some people relieve for 1 year and 2 years. Some people just relieve for a few weeks. But at the end, it works everywhere. This is what's called one fit all, because it can work from the head until the sacrum. This is the only thing. And the training curve is very fast. You can get a mastering very fast because you have a bone to hit this bone. Not like other procedure. Other procedure, if you need to be 95% professional, you need to make a 40 block from each. But here they said about 6 to 12 case you come for professional. And it's working everywhere. And also this looks like an epidural, unilateral epidural. So whenever you need unilateral epidural or bilateral epidural, it can work and give you a very good result. And with lower complication, not like a paravertebral, not like an epidural. I hope to answer you.
Yeah. Very informative answer, yeah, Dr. Yasser. Bless you. There is a question here that honestly I did not understand, so I will invite whoever posted it to ask it. You can unmute the mic. So they're asking about if the curvilinear need more mastering skills than the linear probe. Is that it? What you mean? iPhone? I don't know
Yes,
that.
yes.
I'm very sorry. So you can unmute and ask directly the question to Dr. Yasser, okay?
Yeah, that's what you said, Dr. Hayat. I'm asking, is curvilinear probe needs more skills than linear or not?
I can't see that, but all the time, sometimes you are obligated to use a curvilinear. For example, you just go for genicular nerve. This is a very superficial structure, but some patient, like a baby elephant, like a limb of elephant, so you need this the curved one. Usually, I can agree with you for some extent because the linear one just give a magnified 4 times, give a very good picture resolution, more better. But the problem is the deeper structure. But the curved one give you a smaller structure, not magnified like other one, and also the resolution as the clarity is not so good. So whenever you use, for me, I don't find a problem, but I think it's a very difficult question to see, but I use the two. I don't find a difference, even in some superficial structure, as I told you, like suprascapular nerve, back, sacroiliac joint, and subgluteal sciatic. I use, curvilinear with an isness, but you are right. If you don't see the picture from a curvilinear, it's not typically like a picture from a linear one.
Shukran, ya Dr. Yasser. Another question. They're asking you about the symbol block that you can advise beginners in regional who are trying to master the ultrasound, okay, and to advance their skill to start performing.
Yeah. So if you
Okay.
ask me, just teach me only one block to survive in regional anesthesia, I will see erectospinal block. But you know that if you go for brachial plexus and the procedure can done by auxiliary, it is more easy than to make it infraclav and supraclav. You know, and when I came to Hamad, I found all people making infraclav and thinking that supraclav can make an, it was written in the book, but this is during the time was blind technique, that it make a pneumothorax. And you know, in my hospital in Saudi Arabia, I was making supraclav, like it because it worked fast, it worked dense because the nerve is dense in this area. It's called like by Winnie, that which created by a landmark technique. It's called the spinal of upper limb. So you know everything is changing in Hamad, but you know if I tell you that you go for superficial like a simple block for upper limb auxiliary, if you can do it, erectorospinal another block, and lower limb popliteal sciatic, femoral adductor canal is a simple block, not an, but you know that don't go for paravertebral from the beginning, or you know if you have a difficult case to go by ultrasound to make it in by ultrasound like a thoracic epidural, and you don't know how to do it. So start simple. When you master some block, just go for other, but don't go for deeper block. You know, because now we have 1,000 of block, and everyone you don't find the name now. Being a block and you know eye bag and recto thoracic limb block and pectothoracic limb block. You know, mini block. But if you want to survive, if you learn rectospine in your brain, it will be very great because it can work from the head until the toe. And also, if you just go for the distal block, like an axillary musculocutaneous, sorry, axillary saphenous or the adductor canal, femoral is a very good nerve to go with the superficial, and popliteal sciatic, it will be great.
Okay. And another one, can you recognize live regional anesthesia? Can you organize live regional anesthesia workshop for us, please? ما عارفة كيف بدي أعمل غايته لكن we leave the
Yeah, I
answer to
agree.
the
I did it in Sudan. I did it in Sudan 2 days and it was attendee about 40 for every day. And Dr. Muhammad Hussein telling me some people waiting and some people coming from far away. I know how difficult to travel in Sudan from far away. So if you have a place and preparation, organization, I'm happy to do it, even in Qatar and everywhere. I did one in Qatar, and the second day I did another one in 2 days, one regional, one being in Alexandria. I just came from Alexandria conference. I don't have any problem. Just invite
She meant
us.
online, yeah, Dr. Yasser, I think. She meant online.
Online will be difficult. You need
Yeah. Sorry. Dr. Yasser, unmute yourself. I think I muted you by mistake. I was trying to mute someone who was a bit loud. Sorry, I'm very sorry about that. So this is the thing. That's why I said I'm not sure, because she meant online, because it will be difficult for people on Sudan now to do it like, hands-on with you. So is it possible or feasible?
very difficult because hand-on need and to handle the hand is called the hand-on, and to teach him how to what's called to touch the probe. You know that I tell you ultrasound like a driving a manual car. When you drive a manual car, you need what's called a mental physical coordination. You can imagine when you drive a manual car what happened first. So I can't tell you just to do that and to go for drive. It's very difficult. You know, it must workshop, it must be hand-on. It can be, you can just collect some people, a little number. We do that in Saudi. A little number to go anywhere and to bring a machine, a company to bring a volunteer and teaching him even 2 sessions only. I think it can be anywhere.
تمام. قال لك إن شاء الله in the near future they will try
to
organize one in Port Sudan.
I make the best, for me, the best workshop, Muhammad Hassan and his colleague. You know that they bring me in the morning in the OR and they agree with 6 cases or 5 cases to do it. And the people in Sudan very kind. So about 30 person around the man, and I make a block and I bring.
Inshallah, soon they said they will organize.
And they don't say anything, asking a lot for me. And I make about 6 cases. It never happens. It's usually hand-on volunteer. But we make, and again the second day, and even for pain, they bring me about 5 cases. We make it in Khartoum hospital, and some people were suffering for a long time, you know. And I like it. I like this organization, to bring a patient like
إن شاء الله
but
soon يا دكتور رضا will organize إن شاء الله الأمور تستقر في السودان. Things will settle and we will do it. They're asking you about the websites that the resources to help and guide people who want to
if you need
learn
anything,
more.
just give him. You can give him my contact number.
Okay.
Just send
Okay.
me and
you will send
WhatsApp.
them
I will send you
resources.
resources. Yes.
No worries. This is very kind from you. Anyone want resources from Dr. Yasser Rida? Just text me in private and I will link you with Dr. Yasser. They're asking me you as well if you
حياك الله
recommend.
حياك الله بروف ياسر.
السلام عليكم محمد حسين.
Yeah. You recommend any book?
I recommend many books. I will just give him a good books just to start with.
No problem.
I think there is one hand, Hayat, one more chance. There is one hand up in the, I think this is Yasser. Just give him a chance.
Yasser, he's the only one who's raising his hand. Everyone is.
He's a very polite. He's one of my
very
best,
polite guy.
my team, one of the best.
Thank you for calling me a polite doctor. That's really privilege. Thank you, Dr. Yasser, for the great lecture that we enjoyed. And actually, I know now the situation in Sudan is not nice, and a lot of colleagues they asked about the workshop, and so if you just give them a quick hint regarding the ergonomics and how to improve the needle-eye coordination. At least these fewer blocks they are going to start under supervision. But when they having some free time, how they can improve these 2 points, because they are a little bit important: the ergonomics and the hand-eye coordination. Thank you, Hayat and Dr. Yasser, for the lecture.
Thank you.
Welcome, Yasser. It's a pleasure.
You know that, Dr. Hayat, because of that, Yasser, this is a very important thing. In most of the conference, they bring like a gel to train the people there and to see the needle in a better way. Also, they bring a meat. In Abu Dhabi last year, bring an sheep and divide it to parts. And this time they bring a meat and teach the people how to guide their needle, because it needs a training. In Saudi Arabia, when I was there, not permissible for anyone to touch a patient without 4-hour training in phantom, whatever the phantom. Maybe meat, soup, chicken, gel, it was called help the people to align the needle and to see. This is like an simulation training when I was in the army with a Newton tank, because the bullet is very expensive. So you are inside the room like a tank and shooting, and you see the record for your shooting. It needs like a simulation, and we have a low validity, like what I said, part of chicken or just a meat or soup or chicken or just a gel or water bath phantom, and it's high validity phantom like a body or part of the body, and computerized system. This is get a high validity, get a many training, but really we don't have this. It's called high validity. Only you have a gel and stuff like this. So, and I think everyone just can buy his own ultrasound now. With the $3,000, $4,000, you can bring the best machine. Because I remember in Sudan, Dr. Ihsan bring a machine, but this during the time of little technology. The machine is needle ultrasound connected to the computer, and when I use it for 3 minutes, it becomes very hot. I must stop it. I can't continue, and we stop the machine for time. But now it's like a Japanese car. The temperature never go up. And I think by 3,000, 4,000, you can bring a very good machine now.
اوكي يا دكتور ياسر، في كومنت هنا من دكتور هداب احنا هنختم به. في اصرار على انه يكون في ديمو اونلاين. دكتور هداب, I'll promise you I will investigate if this possible. He said my resident might be happy to have an online demo of knobology of the needle orientation in plane and out of plane.
I agree with him if you have the technology and the facility to transmit it, and I agree with that. But we tried to do that during COVID, and it was not good. It was get some benefits, but not so good like in real time. But if you have an camera and something transmitted to the people and showing how to scan, how to put a needle, all this stuff, I agree with you. I'm just ready at any time. You decide to do it, but we need some what's called technical issue to help to transfer for all this people.
شكرا يا
and
دكتور ياسر.
شكرا يا دكتور عتاب، وحشني كتير والله.
Yeah. I think we can conclude now. Dr. Yasser, that was very informative session. It was very kind from you, coming very late from the hospital. I know that you had a very busy day coming out of 2 conferences. So we are really grateful that you, after all this hustling day, you managed to go ahead and give us the lecture. We apologize for all the technical problem and the troubleshooting that happened in the beginning. And we will do our best to see if we can host Dr. Yasser again for an online session or a session or demo online. By this, we conclude our 6th lecture. Thank you,
I'm ready at any time, Dr.
Sudaq.
Hayat. Just order me.
Inshallah. Thank you, Sudaq. Thank you, Dr. Khalid Mahmoud. Thank you, all the audience. Thank you, Dr. Inas. Thank you for everyone who participated to make this possible. Thank you very much.
Thank you very much, Dr. Yasser.
Stop the recording, ya Khalid.